You are listening to the Keep the Weight Off podcast with Dr. Angela, episode number 25.
Welcome to the Keep the Weight Off podcast, where we bust all the dieting myths and discover not just how to lose weight, but more importantly, how to keep it off. We go way beyond the food, and we use science and psychology to give you strategies that work. And now your host, Dr. Angela Zechmann.
Well, hello again, and welcome back, everybody. Today's podcast is part 2 of our discussion with Teresa Owens on diabetes. So she's back with us again this week. So glad to have you here, Teresa.
Hey.
I think, if you have not heard part 1 of what we talked about last week, I'd recommend that go back and listen to that one first so that you can get a good idea of Teresa's story. She told us all about how it was that she was diagnosed with diabetes and everything that she went through from both a mental and a physical standpoint in terms of getting her diabetes under control. And I think that will really help to inform this discussion that we're going to have today about managing diabetes and about the new medications that are out there and about CGMs, a little bit about that. That's a continuous glucose monitor, if you've never heard of that. And we just want you to know that since most people who are diagnosed with diabetes are managed with medications and not with insulin, we're not going to talk so much about insulin pumps or anything like that, but we are going to have a really nice discussion about the medications that are out there. But before we even start talking about that, I want to point out that your most important treatment is going to be your nutrition. Would you agree with that, Teresa?
Yes, plus.
Yes, plus. Okay.
Yes.
Okay, great. So tell me what kind of nutrition recommendations you give your diabetes patients and why you give them those recommendations.
So just like what you talk about a lot when we're talking about obesity medicine and what you talk about elsewhere in the podcast, I talk a lot about insulin resistance and carbohydrates. And so sugar, in my practice, I generally call it carbohydrates instead of sugar. So we use the words interchangeably though. One of the things to remember is that diabetes is a disease of carbohydrate intolerance. So insulin resistance and carbohydrate intolerance go hand in hand. And, we talk a lot in our culture about intolerances. We've got gluten intolerance. We might have somebody who's got an intolerance to eggs or, whatever other kind of dietary intolerance they have. But for some reason, we don't talk about carbohydrate intolerance. And a lot of us are carbohydrate intolerant. And that's what insulin resistant is that our bodies don't tolerate carbohydrates.
They don't know what to do with them. They just don't know how to process them.
Because this insulin resistant has made it dysfunctional in the same way that somebody who has celiac disease is truly intolerant of gluten. Because their body
lactose intolerance.
Exactly. Their body doesn't have the right ability to process that. Those of us who are insulin resistant are intolerant to carbohydrates. So I talk about that a lot. So that's one of the first things I talk about when I'm talking to somebody with diabetes or insulin resistant is the reason that we are limiting carbohydrates is because our bodies don't tolerate them. So it's a disease of carbohydrate intolerance. And so then we start looking at, how do carbohydrates work in our body? I talk about what insulin resistance looks like. And then I take a really individualized approach with my clients. How, we look at what they're eating now. We look at what they're willing to change. And some of them go full on sugar detox, like you talk about in your podcast. And some of them maybe are going to just give up a soda a day. And one of the things that's, I think, a little bit different with diabetes than with weight loss is that there's a lot of emotion tied up in the in weight loss and everything. With diabetes, there's I think another layer of that, in that now there's a chronic life-threatening disease that's associated with it. And I think a little bit more gentle than saying we're going to cold turkey everything. Because already they're looking at, oh my goodness, am I going to have my feet amputated? And now I have to give up my soda. Okay, well, you might have to give up your soda. Probably eventually you're going to want to give up your soda, but we don't have to do that today. So I think that's probably the one place where I have a little bit of a different approach than in a standard obesity medicine appointment. Does that make sense?
Yep. Yeah.
But the other thing and I think part of the reason why this works also is that then I'm giving them a glucometer. So they're either getting something where they're testing their glucose multiple times a day. I'm encouraging them to test after they eat things so that they can see how what they eat affects their blood sugar.
Okay, wait. So yeah, because I just want to make sure, because we might have podcast listeners who don't know what a glucometer is. So.
Yes. So the glucometer, or the glucose meter, is basically the standard one is the one where you poke your finger and you get an instant reading of what your glucose is. And when
glucose is blood sugar.
Yeah. Yes. The blood sugar. So you can know exactly what your blood sugar is at any given time but with a finger poke.
Yes.
So
what should it be?
So somebody who's not diabetic is going to have a blood sugar that's less than 100 pretty much all the time. Most people are going to be, so the fasting blood sugar, which is the one that would be first thing in the morning after not having anything to eat or drink in 8 hours, diagnostic of healthy, according to the algorithms or according to the lab values, is 99 or less. Pre-diabetes starts at 100.
Right.
Diabetes starts at 126. That's that first one in the morning.
Yep.
And then for random ones, even somebody who, somebody who doesn't have diabetes, a random one still is going to be probably less than 100. It's pretty remarkable. They give allowances for it to be higher, but it generally isn't. If somebody's healthy and they have they're not insulin resistant, their blood sugar is not going to fluctuate much beyond maybe 110. They're going to stay right in that really lower range. Somebody with diabetes, we're looking to have after 2 hours after a meal, we're looking for it to be, I think, gosh, it's been a long time since I've looked at these exact numbers. I think it's like 140 to 180.
Right. Yeah.
And, the fasting, we still want it to be, if we can get it below 100, that's fantastic.
Yeah.
But
that can be hard though when you have diabetes. So.
It can, and particularly for people with type 2 diabetes. It's easier to get, it's interesting, and there's a lot of physiological reasons for why, but it's for people with type 2 diabetes in particular, it's really hard to get that fasting blood sugar that tends to be the highest one of the day. It's a crazy thing. Anyway.
Okay. Yeah. Sorry. I interrupted you.
No worries. After that little digression. So when I've got somebody that is, even before they change their diet, sometimes I'll have them just take their blood sugar a bunch of times throughout the day and compare,
just to kind of see where they're at.
Just to see where they're at and to compare it to what they're eating. So that they can see how, when they do drink that soda, how does that affect them?
Yeah.
When they have some French fries, how does that affect them? When they have a salad, how does that affect them? When they have some chicken, how does that affect them? How the various foods affect their blood sugar. It's an amazing way to learn. And, a lot of times so then we start talking about cutting things out, and you see how, okay, so if I'm not drinking that soda, that's, pure sugar, my blood sugar is not going to go crazy high. And I will tell you, I don't know what my blood sugar does when I have a soda, because it's been so long since I've had one, but I know that it would go up by at least 100 points. If I had a soda, my blood sugar would go up by at least 100 points, probably more. And in a healthy person, it might rise 30 points, but it certainly wouldn't go up 100 points.
Yeah.
And it would come down really quick. My 100 points would stay there for a few hours.
Yeah.
So,
so what's the big deal about that? Like, why does it matter if your blood sugar goes up 100 points and stays up 100 points for a few hours? Like, what's wrong with that?
So you've got sugar that's hanging out in your blood that doesn't belong there.
Yeah.
And that's that's one of the problems.
Mm-hmm.
And that is causing, it's going to filter down into all the little tiny places where there's not room for it to be.
Mm.
And all of the nasty, horrible things that we hear about, which we call the microvascular complications, which are the things that cause blindness and kidney failure and amputations.
Those tiny little blood vessels. Yeah.
Those tiny little blood vessels, when they get full of sugar, they die.
Mm-hmm.
So we want to keep you from having really high blood sugar, because those are the things that cause those bad complications.
Mm-hmm.
So interestingly, those high blood sugars are not the things that cause the heart complications.
Mm-hmm.
Those are, it's a whole different podcast. But all those things that when we think about diabetes and we think about, my friend's cousin's uncle that had a double amputation, those are all caused by long-term high blood sugar. We do not want high blood sugar.
Mm-hmm.
So that's why we want to avoid those high blood sugars. So back to the nutrition. So we start talking about cutting out carbs, and I have people compare what's going on with their blood sugar versus what's going on with what they're eating.
I think that's brilliant.
And it self-reinforces.
Yeah.
And I also kind of I encourage them to gamify it. Like how, what happens when you do this? How, show, and I say, make a chart, show me what happens. Whatever is a fun way. And I try to talk to people. My practice is set up in a way that I have time to do this, that we really talk to people. And I kind of figure out what it is about, what part motivates them. Because if it's just amputations that motivate them, okay, we can work on that. But for most people, for a lot of people, it's today, not 30 years from now, that motivates them. So, well, today it might be getting the number to be less than 120 most of the day. So that's where, and you mentioned continuous glucose monitor, and that's where, if I can get it covered by insurance, I like people to be on a continuous glucose monitor. And what a continuous glucose monitor is there is and I have a continuous glucose monitor. I briefly mentioned it in the last podcast. It goes either on a sensor goes either on your belly or on the back of your arm. And it just lives there all the time and gives you a reading all the time. It shows up on your phone. And I can look at my phone at any given time and know exactly what my blood sugar is.
Wow, that's so cool.
It is so amazing. And, and when I first got it, I used to play with it a lot. Like to say, okay, so what happens now? Okay, now I actually I don't think I could tolerate it because I think I would really hate it. But part of me is like, I wonder what would happen. Now that we're talking, I'm like, maybe I want to go drink a soda, see what happens. I think I'd probably throw up. I think it'd be really gross. But,
yeah.
But I'm curious. But part of me is like, huh. And I would be able to watch in real time as my blood sugar climbed on the graph. Oh, wow. So a continuous glucose monitor is a really excellent way to help people learn. And there's and they weren't built to gamify it, those blood sugars, but you can set up goals. And I've even seen some things, because on Facebook, because I have things on my internet that I follow that are about diabetes. I get the Facebook ads that are about diabetes or about blood sugars. I've even seen ads come across Facebook now where there are companies that are using continuous glucose monitors to help people do low carb diets.
Yeah.
Which I think is partly brilliant and partly sketchy, but I'm not sure.
Okay.
But anyway, it's, for somebody who has diabetes, I have a few of my clients who have prediabetes who use them, that are monitoring. It's very difficult to get them covered for prediabetes. So some of them are paying out of pocket for their monitors because they want the information.
What do they cost?
There's two that are, there's the Freestyle Libra, and it is, it does not actually do a full continuous, it's not truly full continuous monitor because you actually have to wave your phone across the sensor in order for it to give you the readings. And I think that one is maybe $100 to $200 a month.
Okay. Well, that's reasonable to learn.
Yeah, it is. And that's the one that
how your body handles different stuff.
If somebody has to pay out of pocket, that's the one that they get. The one that hooks up with the, that's really used by people that have, that are taking insulin, so need it to know whether or not they're going low, is called the Dexcom. And that one hooks up with, the insulin pumps. So it's, so I have, mentioned in the last podcast, I have my insulin pump and it talks to my continuous monitor, makes the micro adjustments. And that one, I have no idea how much it costs. I'm just really glad I have insurance coverage.
Yeah. Okay.
Because
it's got to be way more expensive.
It is. And it does, and the reason that I got it initially is that I have what's called hypoglycemic unawareness, which means that when my blood sugar goes low, I don't know.
Oh.
And that can be very dangerous.
For sure. Yeah.
So I got it initially because I was taking insulin and I didn't know when my blood sugar was going low. Was it dangerously low? People around me might have noticed, but I didn't notice that I wasn't functioning normally. And so the Dexcom gives you an alarm when you're going low.
So for our podcast listeners who might not actually have diabetes, but they're concerned about their blood sugars and they wanted to get a continuous glucose monitor and they knew that their insurance company wasn't going to cover it, you would recommend the Freestyle Libra. Do they need to get a prescription for that?
I don't know. I honestly, I don't know the answer to that because if any of my clients want them, I prescribe them.
Oh, okay.
It's as easy as that. I have a couple of clients that when I've prescribed it, it's worked and they've gotten insurance coverage, and some of them they haven't and they just pay out of pocket.
Yeah.
So,
but I think that's a brilliant idea because you can eat foods and just see how your body manages your blood sugar.
Yeah. It really is.
You make empowered decisions that way. I'm all about teaching people to make empowered decisions. Like,
right?
When you understand the science of what's going on in your body, it is so much easier to make the right decisions, So
well, and honestly, even if you're going to make an educated bad decision, it's like, okay, you own your decision.
Yeah, exactly. I'm making this choice, and I know, as opposed to I'm just drinking sodas all day because that's what I do.
Like soda.
And I have no idea what it's doing to me.
Which is why. I don't like to tell people don't drink your soda, but drink a soda and see what it does to your blood sugar. And then we'll talk next time about soda. And, if they drink a soda and see what it does to the blood sugar, when they come back, they're probably not drinking soda. Or if they are, they've given up every single other carb in their life because they really want to keep their soda. So anyway, so that's where I fall in nutrition is like, let's get the carbs as low as we can. And generally it's about teaching
your patient
what it does to their bodies
to make informed decisions. Yeah. Okay. That's cool.
And I think it's really empowering that instead of me saying, you need to do this, them coming to the realization and me coaching them along that, this is probably going to be a better decision, but why don't you see for yourself what it looks like?
Yeah.
That, it's more collaborative. It feels better for everybody. And then if there's rebellion, it's not against me, it's against themselves. Like I said, I think I mentioned last time that sometimes I have, little toddler tantrums, because it's helpful to have little toddler tantrums for me to get my anger out. And then they're over, if I'm making a rebellious decision, it's against my own self. It's not against what my endocrinologist told me, because she and I work in collaboration when we're deciding what my treatment plan is.
Mm-hmm.
I want the same thing with my clients. I want
Yeah.
them, we're working together. If you make a decision that's different than that, it's not because I told you to do something and you're mad at me. It's because you want to figure that out yourself,
Mm-hmm.
and we'll work that through.
Yeah. Great.
So,
okay.
Yeah, so that's where I fall in nutrition.
Awesome. So, and you generally try to, you don't usually recommend a keto diet in somebody with diabetes, because we talked about this last time, you need to be making insulin.
So it depends. And first of all, I don't generally recommend a keto diet unless it's something that somebody comes to me and says, I really want to do a keto diet.
Yeah. And I always say, you need to be willing to live a keto lifestyle, not just do a keto diet.
Exactly. And there's, and not just because you read about it on the internet and because it's what bodybuilders are doing. I think you and I pretty much eat keto most of the time, but that's because that's the food we like. And that's because that's how the people we hang out with eat. And that's, it comes easy, but it comes easy because that's how we live, not because, it's not hard to make. I think you should only eat keto if it's easy for you. I guess is my thing on that. So as far as a ketogenic diet goes, if you know for sure that you make plenty of insulin, I have no problem with somebody doing a ketogenic diet. The one caveat to that is a medication that we're going to talk about a little bit later, that nobody should be doing a ketogenic diet on that medication unless they're closely monitoring their ketones.
Okay.
So, and then again, I would say I would want them talking with their medical provider about that. I would not, I have a couple patients that do take that medication, do ketogenic diet, but they're really closely monitored by me. I would never recommend to somebody else that they do that diet and that medication without being closely monitored by their own medical provider.
Got it.
So
cool.
I would never say you should do this without talking with your own provider and having them monitor you, not just talking about it, but know what's going on with you.
Yeah. So what medications do we use in diabetes these days? There's so much going on. It's hard to keep up sometimes.
It is. So the first line medication has been for the last 25 years, probably 20 years at least. Actually, I wouldn't say 25 years. I want to say about 20 years, has been metformin, and it still is. And it's cheap. Everybody knows how to use it. Most people tolerate it really well when it's prescribed in the right manner. So people talk about horror stories with metformin, but generally those come with it not being prescribed in a way that is tolerated very easily. And I'm going to talk about, I'm going to say how it's better tolerated in just a minute. And I want people to pay close attention to this, because if it's prescribed differently than that, I want you to talk to your provider about this other way that you've heard it prescribed. I'm not saying that I'm not your medical provider.
Yes, we're not giving medical advice here.
But I do want you to talk, and I don't want you to change the way they're doing it. I want you to talk to them and ask them if this might be tolerated better for you. Because a lot of times, first of all, providers don't believe it when patients tell them that it's not well tolerated. And I will tell you that when I first took metformin, I do not tolerate metformin well at all. I take metformin. I don't take it anymore, but I used to take metformin because the benefits were so astounding that to me, they were worth the horrible side effects. And the side effects for me were truly disastrous. And it was, and so when people say, oh, I don't believe the side effects are that bad, I'm like, well, that's because either you haven't tried it, or if you did try it, you did not have the disastrous side effects, because they can be very severe stomach upset and severe diarrhea. And having said that, that does not happen to most people. So, and it doesn't happen to most people, particularly when it's prescribed appropriately. So, when I say it prescribed appropriately, the best way to take it is generally through the extended release version. So there is an extended release version and an immediate release version on the market. A lot of providers don't prescribe the extended release version because it used to be that the extended release version was very, very expensive.
Yeah.
It is no longer very expensive, but a lot of providers don't realize that it's not expensive anymore. And so they're still prescribing the same one that they used to prescribe. And so I never prescribe the immediate release version.
Neither do I. Never.
The one exception to that is somebody who's had weight loss surgery, and that's because they can't take extended release versions of anything. But other than that, there's no reason to give anybody the regular release version of it. But again, a lot of providers don't because they used to have, if they prescribed the extended release version, they had to go through insurance companies, or patients would say, I can't do it because it's so expensive. They don't realize it's not expensive anymore. It's still under $10. If not, like a lot of insurance covers it completely. You don't have to pay anything for it. So that's one thing. The other thing is that a lot of times providers will say, I want you to, they want you at a specific dose eventually. And they'll just say, here's the dose I want you at. Go start taking this dose. And suddenly your body that's never seen this medication before is taking this medication that can be really hard on your stomach without having a chance to adjust to it. Yeah. And so we call that titrating. And so we want to start with what we call a titration dose, where we start with a low, take 1 tablet a day instead of 4 tablets a day. So if your doctor's prescribing metformin and they're prescribing the standard release with a full, say, 2,000 milligram dose, and they say, just start it. Well, your stomach is going to be, you're going to be in worlds of hurt. This is not going to go well for anybody.
Yeah.
Even if you're going to tolerate it really well later, that is just a recipe for disaster. So if that happens, first of all, say, you know what, I read somewhere or I heard on a podcast that there might be a better way to take it. I'm really afraid I'm not going to tolerate this. Can we talk about doing it differently? And if you explain to them, it's not expensive, or, I checked with my pharmacy, or I looked up on GoodRx what the price is. It's not that expensive. I can afford this. I'd really like you to prescribe this one. Check with them and they'll probably prescribe the other one. And they'll have learned something new too. And it'll probably help them when they're talking to their next patient.
Yep.
So,
metformin.
So metformin is the place to start. Yes. Yep. And then after that, the next place that a lot of providers go is to a class of drugs that is actually not even on the algorithms anymore, which the algorithms, the charts that recommend. So there's 2 organizations that put out these charts. There's the American College of Clinical Endocrinologists, and there's American Diabetes Association. Neither of them recommend as the second line, but many providers still prescribe as the second line a class of drugs called sulfonylureas. And those are the drugs that are known at, those are drugs like glimepiride and glyburide and glipizide. So the IDES is what I call them.
Yes.
And those are drugs that cause your pancreas to release more insulin. So the reason that people go to them is that they are covered by Medicare and they're covered by insurance, and they are dirt cheap. So they're super cheap. They're easy to prescribe, and nobody has to do any paperwork. The problem with them is that, and this is the reason why they're not on these charts anymore and not recommended anymore, is that they can cause people to have low blood sugars, which is a problem. Because if you have low blood sugar, you can get dizzy, you can pass out, you can become disoriented. Plus, it just doesn't feel good. And it's not healthy for your body to have low blood sugar. So they can cause low blood sugar. And the other thing is that there's some evidence that they might wear out your pancreas cells that you want to keep going as long as possible. You want to keep them functioning as long as possible.
So they lower blood sugar by actually stimulating your pancreas to produce more insulin.
Yes. So we don't want that.
We don't want that.
Yeah. So, again, there may be a reason that your doctor is prescribing that I don't know about. And that again would be between you and your provider, but those drugs aren't even showing up on the recommended medication charts.
Yeah.
The next, so there's 3 different classes of drugs that are pretty equal on the next class of medication, the second line medication. So it's always metformin first. And then the recommendations for the next 3 are a drug called, the class is called the DPP4 inhibitors. I think they're DPP4 inhibitors. And that drug, the one that's most commonly known as the brand name Januvia.
Yep.
So that drug works in a similar pathway to the next drug that I'm going to talk about. I will say I've never prescribed this drug because I don't see that it has any benefit over the next drug that I'm going to talk about. But the one benefit that it has is it's an oral medication. It tends to be the one that a lot of people go to as the second line before the next 2 that I'm going to talk about because there's better insurance coverage for it usually.
Okay.
And Medicare covers it without as much of a hassle. So, again, unfortunately, a lot of these things are dictated by where insurance coverage comes from.
Exactly. Yeah.
So,
it's frustrating.
there's not a problem with this drug. There's no reason to say this is a bad drug. I just don't think it's as good as the other 2 that I'm going to talk about in a minute.
Okay.
And the reason, so the next class of drug that I'm going to talk about is called GLP-1 receptor agonist.
Yes.
So these are the drugs, the most common ones that you'll see advertised. It used to be that Victoza was the one that everybody knew about, and that was a once daily injection. The very first one on the market was Byetta. That was a twice daily injection. I took that one when it was brand new. I think I started taking it just 3 or 4 months after it came out. It was remarkable, and it was a big deal to be taking that drug. I was really excited about it. And now there are long acting versions of those drugs that are once weekly. And so the one that you'll hear the most about because it's advertised everywhere is Trulicity. But there's a few, Trulicity and Ozempic are the brand names that I know the most of those long acting ones. You may also be familiar, this is the same class of drug as the newly approved anti-obesity medication. And I don't know how it's pronounced. Is it Wegovy?
Something like that. Yeah.
Wegovy. Wegovy, maybe. Anyway, same class of drug as those. So if you've just heard me say it's the same class of drug as those anti-obesity drugs, the big thing that these drugs have going for them is that they can have a lot of weight loss associated with them. And that's one of the things that I really like about these drugs. Over Januvia is that all of the drugs in these class have weight loss associated with them. So Januvia, the big difference between Januvia and these GLPs is what we call them, is that Januvia is what we call weight neutral. So you don't gain weight, but you also don't lose any weight on them.
It's nice the GLPs really do help with weight loss. And also, did you know that there's an oral form now too?
There is. I have not heard of anybody getting it covered by an insurance yet.
Yeah, there's a $10 coupon. So some of my patients have been.
Oh, have they?
There's just always so much to think about when it comes to these medications. This for our podcast listeners, it all depends on your insurance. But we just want you to know what the options are.
Yeah. And I will say, I haven't even tried because I'm just I've gotten really good at getting the injectables covered that I kind of know the tricks to get the injectables covered. So I haven't even tried. And most of my patients are really good. So one of the things, a lot of times when people think, oh my goodness, it's an injectable, it must be insulin. It is not insulin.
It's not.
It's not insulin at all. A lot of people also say, oh my goodness, I've failed because I have to take this drug that's injectable. No, it's not. A lot of people also are afraid because this injection is going to be painful. The daily ones especially are tiny, tiny little needle that you barely even notice. It's not painful. I say this as somebody who's taken thousands of injections now in my life. I don't even notice it. I will say that Trulicity isn't pleasant, but it happens once a week and it's not the end of the world. It's not, again, it hurts less than putting the sensor in my arm.
Okay.
So it's not that big a deal. And it takes less than 5 seconds to do it. So, they're pretty easy. And for a lot of people, I have them pick it up at the pharmacy and bring it in, and we do the first injection in my office.
Awesome.
Or we do it together over video.
Okay.
So it makes it a little bit easier. I talk them through it, and we can just do it together. Because a lot of it, there's fear behind how does it work. Yeah. If you've never given yourself an injection before, it can be really frightening.
Yeah.
It's really not that big of a deal.
Yeah.
It seems like it is, and we really, really work it up in our brains. But when push comes to shove, it's not that. Take a deep breath and be done with it.
Yeah.
So that's the next class. And then the third class of drugs that is also recommended second line behind metformin by these two tables is a class of drugs called the SGLT2 inhibitors. And these are the drugs, the brand names that I know are Invokana and Jardiance. And there's another one that's really common. I also call them the Flozins. Anyway, these drugs are, the way that they work is that they filter the sugar out in the kidneys. And so you basically pee out the excess sugar. You take in the sugar and it pees out the excess sugar. And it's pretty remarkable the way it works. There's a few downsides to them. One is that they can cause yeast infections, particularly in women who are prone to yeast infections. So if you are prone to yeast infections, pay attention to that. I do not think that is a reason not to take this drug. It depends on how bothersome the yeast infections are. If you have, some women with diabetes already have chronic yeast infections, and maybe they need to be taking a medication to prevent those chronic yeast infections. And this drug, unless, you're suddenly getting yeast infections and you never had before, and these yeast infections are big and bad, that might be a reason to stop. But I think that these are drugs that are worth trying, and and they're really excellent at lowering the blood sugar by a couple points of A1C. They also are excellent for weight loss, like the and I forgot to mention about the GLPs and this drug also have cardiovascular benefits that have been proven now in studies as well.
Yes.
So it's pretty remarkable that the Flozins have, so this SGLT2 class also have kidney indications as well, because they help with kidney function.
Yeah.
So they're pretty remarkable, these medications, the things that they're finding out that they can do. This is the drug that I was mentioning, however, that you absolutely should not be doing a ketogenic diet when you are on this medication. Unless your medical provider is very aware that you are doing a ketogenic diet and they are monitoring you. So do not do a ketogenic diet on your own if you are taking an SGLT2 inhibitor. So that's Jardiance, Invokana, any of the Flozin drugs, because they can be dehydrating. And they can, if you are insulin deficient and you didn't know you were insulin deficient, they can bring your blood sugar down so things look like they're going really well. But then you could have what they call euglycemic ketoacidosis, which means that your blood sugar looks great, but you end up in the hospital with ketoacidosis.
Mm-hmm.
And that is very bad.
Yeah.
So that would be the big warning that I have about that drug.
Mm-hmm. Yeah.
So the other thing about all these drugs, those 3 drugs that I just mentioned,
or 3 classes of drugs, basically.
3 classes of drugs. Yes,
Yeah.
3 classes of drugs. Plus metformin,
Mm-hmm.
is that you can stack them.
Right.
So when you're taking metformin, the recommendations are that, so a lot of times I'll have somebody come in and say, oh, I really want to try and do this all without medication because I just, I know I can do this without medication. And I hear
that all the time.
Right. And my first response is, okay, we can try that. But I want to talk a little bit about what the motivation for doing it without medication is.
Mm-hmm.
And also I want to talk about the fact that the quicker we get things under control, the less likely it is to progress quickly. Fastly, that's a word I just made up. The less likely it is to rapidly progress.
Mm-hmm.
So I would rather get somebody started on medication right away and be able to drop the medications later.
Yeah. That's one thing that people don't understand. It's like, if you can get diabetes under control very quickly, your long-term outcomes 10 years from now are so much better. And the research is really validating that.
It is. The research is solid on that.
Mm-hmm.
Yeah.
Yeah.
And the earlier, the faster we can get things under control, the better, which is why. So if somebody says is really absolutely firm in their conviction that they don't want to do medication, okay, the longest I'm going to give them is 3 months.
Mm-hmm.
If you can turn it around in 3 months, then we'll talk.
Mm-hmm.
But, I'll say, okay, so here's the things that you really need to do. And then these also need to be things that you're willing to do for the rest of your life and not just for 3 months.
Right. Yeah.
So, it's not just to show me that you can bring your A1C down in 3 months. It's to show me that you can bring your A1C down and then you can keep doing these things for the rest of your life, because diabetes doesn't go away.
Yeah.
It can go into reversal, but doesn't go away. Your body is still going to be there. So, so I want to start on medication right away. If metformin in 3 months, this is what the table recommends. If metformin doesn't work in 3 months, then you add a second agent.
So that's what you mean by stacking.
You're going to stack medications. So you've got, so say I start metformin on somebody and in 3 months later, and when I say 3 months later, I say 3 months after they've gotten up to the full dose that they tolerate.
Right. Yeah.
So it might take them 2 months to get up to the dose of that we want them to.
Mm-hmm.
So if they're, so if 5 months later, they're still not at what their A1C goal is, the blood sugar goal that we want them to be at, then I'm going to add another drug. And so we're going to talk about which drug we want to add. So say we're going to add one of the Flozins. So the one that, because they don't want to do an injection yet. So we're going to add the one where they pee out the sugar.
Mm-hmm.
So fantastic. So we're going to add that one. 3 months later, their blood sugar's better. They've doing their lifestyle work. Things are looking better, but they're still not at goal. We've got 2 other drugs that we can try. Now, we would never stack the DPP-4, which is the Januvia, and the injectable that I talked about, those GLPs, because those 2 do the same thing. Even though they're different class of drug, they do the same thing, even though they do it differently. So then I would choose either the Januvia, the oral one, or the GLP, the injectable one. And if weight loss was an issue and they wanted to work on losing weight, then we would probably recommend the injectable. Yeah, the GLP. But if they really didn't no, I'm not going to take an injectable. Okay, then we'll do the DPP. And then we'll still, we keep stacking
Mm-hmm.
And then if they're still not managed after that, that's when we start looking at adding insulin.
Mm.
So,
Okay.
and we're not going to talk about insulin today, other than to say that at some point, because we do really need to worry about those long-term microvascular concerns.
Mm-hmm.
That,
yeah.
Because we don't want blindness, kidney failure, and amputations.
Well, there's another treatment that you have not mentioned yet.
I haven't. And I love this one.
Yeah.
And people don't love this one, but I do. And that is bariatric surgery. That's weight loss surgery.
Mm-hmm.
And people think, well, weight loss surgery, how does that fix diabetes? And the answer is nobody is quite sure how.
Yeah.
But it does. And I just watched a lecture just yesterday, and I wish that I had written down the statistics on this. And I will give them to you, Angela, to post with your notes on what the percentages are of how many people put their diabetes fully into remission. So when I was a baby registered nurse working my first job on a hospital floor, they were doing bariatric surgeries on that floor.
Mm-hmm.
And I'm not sure if I ever told you this story. This is the first thing that made me interested in obesity medicine. I would see patients before they would go for surgery, and they would have a sliding insulin scale, taking just loads and loads of insulin.
Mm-hmm.
And I'd see them the night before, they'd check in for their surgery the night before, and, I'd give them insulin. And then the next day after their surgery, they would have their sliding scale, and they never needed insulin again. That's how fast this surgery worked.
Wow.
They came out of surgery not needing insulin.
Yeah. That's incredible. Well, I've heard statistics that it's a 78% cure rate. That's from a few years back. I don't know what the more recent statistics are.
I think it was higher than that. So part of it is, it does, and this is the thing that was interesting about the statistics that I saw in this lecture that I saw yesterday, was that he broke it down into how long it had been since diagnosis. And this is the important thing, is that the earlier following your diagnosis that you get the surgery, the better the results are. Just like the earlier that you get on getting these, that you get your diabetes under control initially, the better your long-term prognosis is, the better. So if you stack a few drugs and you get your A1C down and you get your diabetes under control, you might be able to come off some of those drugs. You might not, you might stay on them, but your blood sugars are more likely to stay under excellent control longer term. The earlier you do that stuff, the better the results are. Yeah. The easier it is to make those, to get your body to respond. The longer that it's been since your diagnosis, the data on how effective it is goes down. Yeah. So it's still going to help. It's still going to improve your insulin sensitivity. It's still going to, because you're going to be losing weight, but it's not going to have as dramatic an impact as, and the impact won't necessarily be as long lasting. And I saw a statistic one time that showed how long the remission stays. And it was remarkable. Like, it puts people into remission for like 7 to 10 years before they even start getting their diabetes back, even if they're gaining some of their weight back.
So the moral of the story that I'm hearing from you, Teresa, is if you've got a diagnosis of diabetes, don't be afraid of medications. Don't be afraid of surgery. Do whatever the heck it takes to get this under control and keep it under control as quickly as you can.
Yes.
So that you can live a more normal, happy, healthy life.
So you can take your grandkids to Disneyland.
Yeah.
I mean, what is the thing you want to do when you're an old lady or an old man? I mean, I want to do those things. And that's honestly one of the other things that I talk about with my patients is, what's your motivation? Why do you want to live a long, happy, healthy life? Why do you want to be able to, like, one of the things that really motivates me is I love seeing beautiful things. I am so motivated to keep my blood sugars down because I can't imagine losing my eyesight.
Yeah.
I just can't even imagine not being able to watch the sunset. I can't imagine not going for a walk. And I mean, it drives my husband crazy when we go for walks that I have to stop and look at every flower. But I can't imagine not stopping and looking at every flower and talking to every kid.
Yeah.
And what would happen if I lost my eyesight? I wouldn't be able to do that anymore.
Right.
And that motivates me so much.
Yeah. Yeah. So find out what your why is for getting your diabetes under control and then work
do
really
it
hard and do it. Yeah. And then the other thing I'm hearing you say is don't be afraid to talk to your healthcare provider about new and different treatment methods if what you're doing isn't working. Right?
Absolutely. And I will say
and don't blame yourself if it's not working either.
Don't blame yourself. There could be something going on with you, not wrong with you, but your body could be saying, well, this isn't the thing that works for me. It could be that there's something more that needs to be learned. So not only don't be afraid to talk to your provider, but if you talk to your provider and your provider isn't receptive and doesn't want it, it's okay to shop for a different provider. Yeah. I think it's really important to have a provider that you can be in a teamwork with. And, we don't do that a lot of times. We think, okay, well, we've been so trained in our culture that people that have medical training, they know what's best. So I need to pay attention and do what they tell me to do. Well, you only have your body. And it's your body and you are the boss of your body.
Yeah.
So if you're not getting what you need from your provider and they're not taking your concerns seriously enough, it's important that you find somebody that's going to work in collaboration with you.
Find somebody you can talk to. Yeah.
And honestly, that's like one of the biggest things that drives my practice is that, I want to be that for my clients and that, that they haven't been listened to. A lot of them haven't been listened to because they have excess weight. And so people think, well, that's why whatever is happening. And so, that really drives my practice. I want to be that for them. I want them to have that collaborative feeling that they can get. Yeah. And so I want everybody to be able to have a provider like that. So if you're not getting that, there's somebody out there for you. Find them.
So we're going to actually, you're going to send me links to the charts that you were talking about from the American College of Clinical Endocrinologists.
Yes.
So that people can actually have, some sort of guidelines that they can take in and show their provider and say, hey, here's what the recommendations are. And I'm interested in expanding my treatment options. You could use those words.
Exactly. And again, it's a it's not a do this, I'm the boss of my body, because they are the people that have the medical knowledge. Yeah. I'm here sitting in a room somewhere. I don't have the medical knowledge of anybody that we're talking to right now. So I don't know, but you have the knowledge of your own body. Your medical provider has their medical knowledge, and together you should be able to come up with what works for you. So, but doing it in a collaborative way. And I think I think it was the last podcast that I mentioned that I took that I was tried to be very respectful whenever I took information to my provider and to acknowledge that she was the one that had the medical knowledge. But this was information that I found and I wanted to try. And I never asked her to make the change at that appointment. I always said, can you please review this and let's talk at our next appointment? Or can you please review this and I'll schedule an appointment next week? Or can we have a phone call next week?
Yeah.
Because, I didn't want to put her on the spot and have her need, I didn't want to say, I know more than you know.
Right. Yeah.
Because at the end of the day, she was still the one with the medical knowledge. I wasn't. I was the one with knowledge of my own body.
Yeah.
And I read my article.
Awesome. All right. Well, this has been so awesome, Teresa. Thank you so much for educating us about diabetes and what it's like to live with diabetes. And there's just so much to know. I feel like we could just go on and on and on. So,
right? I could talk about diabetes forever.
Yeah. So, but it's a huge piece of weight loss medicine. And really, those of us in the field of weight loss medicine, we understand that diabetes is out there and prevalent, and we need to know about it. So I really, really appreciate your taking the time to educate all of us. Do you have any last minute thoughts at all?
Don't be afraid to do it early and get it done.
Yeah, I think I would say that too.
Yeah.
And don't be afraid of surgery either.
Yeah. And that was the thing that really stuck out to me was that I think they said 1 in 160 people that it would benefit are getting surgery.
Yeah. Mm-hmm.
Was the statistic that
and the quality of life is so much better after surgery. I mean, it's a really remarkable thing that they do. So, yeah.
So, and I've seen lives completely changed by surgery. And like I said, it totally blew my baby nurse mind when I saw firsthand what was happening to these people and their insulin needs. So it's pretty remarkable. But yeah.
Awesome. All right, great. Well, thank you so much. And thanks to all of our podcast listeners. If you have any questions or comments, just go to journeybeyondweightloss.com/blog and type in your question or comment, or you can go to YouTube to Dr. Angela Zechmann on YouTube. The podcast gets posted there as well. And if you are interested in having Teresa as your advocate and healthcare provider, tell them where they can find you.
So that only works if you are physically in the state of Washington, because that's where my license allows me to treat people. But I do see people. I do see people virtually. So you can be anywhere in the state of Washington. That works. And you can find me at emeraldcitywellness.org.
emeraldcitywellness.org. And we'll put a link up on the show notes for that as well. So awesome. Well, thank you so much, Teresa.
Thank you for having me. It's been a delight for me too.
All right. So bye, everybody, and we'll see you next week.
Hey, if you really want to lose weight and keep it off for good, your next step is to sign up for Dr. Angela's free weight loss course, where you're going to learn everything you need to get started on your weight loss journey the right way. Just head over to journeybeyondweightloss.com/free course to sign up. Also, it would be awesome if you could take a few moments and write a review on iTunes. Thanks, and we'll see you in Journey Beyond Weight Loss.